Welcome to This Week in Rheumatology. This week we're covering 10 notable papers spanning targeted synthetic and biologic therapy across spondyloarthritis, psoriasis, and myositis, treat to target and prognostic thinking in lupus, lupus nephritis and IgG4-related disease, and health system questions about early referral, biosimilars, and cancer screening. Let's dive in. We'll start with JAK inhibition, which appears twice this week in very different settings. In the Annals of the Rheumatic Diseases, the Phase 3 OLINGUITO program tested filgotinib, a JAK1 preferential inhibitor, across the full axial spondyloarthritis spectrum in 2 parallel randomized, double-blind, placebo-controlled studies of patients with either radiographic or non-radiographic disease who had failed at least 2 non-steroidal anti-inflammatory drugs. Both studies met their primary endpoint at week 16. In radiographic axial spondyloarthritis, roughly 2 in 5 patients on filgotinib achieved an ASAS-40 response versus about 1 in 5 on placebo. And in non-radiographic disease, the figures were about 1 in 3 versus roughly 1 in 6. Separation began as early as week 1, and benefit was seen regardless of baseline C-reactive protein or prior biologic exposure. Secondary endpoints supported the primary, with significant improvements in the axial spondyloarthritis disease activity score, and in magnetic resonance imaging, sacroiliac joint inflammation in both studies, and in function and quality of life in the radiographic group. Through week 52, there were 2 myocardial infarctions, 3 cases of herpes zoster, and 4 malignancies excluding non-melanoma skin cancer. And note, the trial design used response-based dosing after week 16 for patients over 65 or with risk factors, which reflects how these drugs are actually being used post-oral surveillance. Practically, this adds another oral option for axial spondyloarthritis, though safety framing still matters in older cardiovascular risk patients. Alongside that, Seminars in Arthritis and Rheumatism reports a Chinese retrospective cohort of 40 adults with dermatomyositis treated with upadacitinib and followed for 6 months. Disease visual analog scores fell progressively, with improvements in skin involvement, interstitial lung disease, and manual muscle testing, and mean daily glucocorticoid dose fell from roughly 29 mg to around 11 mg by 6 months. That steroid-sparing signal is what will interest clinicians, but this is uncontrolled, small, and the infection burden was substantial, with 17 patients infected including 6 with cytomegalovirus viremia, and 3 with herpes zoster. 4 anti-MDA5 positive patients worsened or relapsed. Treat this as hypothesis generating, not as evidence to displace established regimens. The second theme is interception and early diagnosis, where 2 papers ask whether we can change the trajectory of disease rather than just treat it. In rheumatology, a real-world cohort from 2 university dermatology, rheumatology centers followed 393 patients with psoriasis on biologics between 2008 and 2025, of whom 86, about 22%, went on to develop psoriatic arthritis. Among patients exposed to a single biologic class, progression to psoriatic arthritis was more frequent on tumor necrosis factor inhibitors than on interleukin-17, interleukin-23, or interleukin-12/23 inhibitors, with adjusted odds and hazards for the non-TNF classes roughly a quarter to a fifth of those seen with TNF inhibitors. Importantly, and the authors are appropriately cautious here, when patients were analyzed by first biologic received, the differences disappeared. That inconsistency, plus the retrospective design and obvious channeling bias, means this is a signal for prospective interception trials, rather than a reason to change your psoriasis prescribing today. Complementing that, the Lancet Rheumatology reports long-term outcomes from the Dutch Early Arthritis Recognition Clinic, where rheumatologists screen general practitioner-referred patients for clinical arthritis by joint examination. Comparing 122 patients with rheumatoid arthritis identified through that pathway with 342 referred conventionally in an earlier era, screened patients had lower disease activity and less functional disability across 5 years and were roughly twice as likely to reach sustained DMARD-free remission. Median general practitioner delay was cut from about 9 weeks to about 5. The comparison is historical rather than randomized, so secular change in care is a real confounder. But this is among the first data suggesting that actively shortening diagnostic delay translates into better long-term outcomes, not just faster treatment starts. Our third theme is response assessment and treatment strategy in the connective tissue diseases and IgG4-related disease. Rheumatology asks whether the EULAR early proteinuria targets in lupus nephritis actually predict where patients land at a year. In 132 patients with biopsy-proven disease, of whom about 70% achieved complete renal response at 12 months. Hitting the 25% reduction at 3 months and the 50% reduction at 6 months was strongly associated with complete response, but the operating characteristics matter. Sensitivity was high, around 86 to 89%, while specificity was only 40 to 45%. In other words, missing the early target is a genuine warning sign, but hitting it is weak reassurance, and in patients with nephrotic range proteinuria at baseline, the targets performed poorly, with specificity as low as 17% at 6 months. So in your heavy proteinuria patients, early target attainment should not be read as permission to relax surveillance. Staying with lupus, the European multi-center effort SLE study in rheumatology looked at 47 patients treated with anifrolumab who had at least one disease-related hematologic abnormality at baseline. Complete hematologic response, defined stringently as normalization of every affected lineage, was reached by about 19% at 3 months and cumulatively by around 36% overall, with hemoglobin, leukocyte and lymphocyte counts improving significantly by month 3, while platelet counts rose only non-significantly. Higher baseline C-reactive protein, erythrocyte sedimentation rate and disease activity predicted failure to achieve complete response, and a quarter of patients discontinued. This is retrospective and uncontrolled, but it supports a hematologic benefit signal for a drug licensed on skin and joint endpoints. And from a 12-year prospective Chinese cohort, also in rheumatology, 259 patients with IgG4-related disease experiencing their first relapse were compared according to how treatment was intensified. Intensifying both glucocorticoids and immunosuppressants reduced the hazard of further relapse by about 70% compared with adjusting immunosuppressants alone, while glucocorticoid intensification alone showed a non-significant trend in the same direction. The effect was most pronounced in those with internal organ involvement, and a decision tree found that patients whose responder index fell to 2 or below and whose IgG4 dropped by at least a quarter were most likely to stay relapse-free. Finally, 3 papers address safety and system-level practice. Seminars in Arthritis and Rheumatism reports on nearly 2,000 Chinese patients with idiopathic inflammatory myopathy, of whom about 9% had cancer-associated myositis, most commonly lung, breast and thyroid cancer, with 3/4 of malignancies occurring within a year either side of myositis onset. The IMACS screening guideline correctly flagged about 2/3 of cancer cases as high risk, but also placed about 2/3 of cancer-free patients in the moderate risk category, so its specificity is limited. Adding anti-SAE positivity, elevated C-reactive protein, elevated CA-125, and absence of interstitial lung disease improved discrimination meaningfully. In rheumatology, a Veterans Health Administration cohort of 1,717 patients compared the rituximab biosimilar rituximab PVVR with the originator in rheumatoid arthritis and found no clinically meaningful differences in effectiveness, including prednisone discontinuation, or in safety, including infection-related hospitalizations. That is reassuring real-world evidence in an older comorbid population where biosimilar switching is often questioned. And a small but relevant study of 13 women with refractory lupus who received anti-CD19 CR T-cell therapy with standard lymphodepletion found anti-Mullerian hormone levels unchanged at 12 months, with only a modest rise in follicle-stimulating hormone and no decline in ovarian reserve markers. With the median age of 27 and no comparator group, this is preliminary, but it is the first reproductive endocrine data in this population, and it is broadly reassuring for fertility counseling. If you only have time for one paper this week, make it the Lancet Rheumatology Early Arthritis Recognition Clinic study. It is a rare demonstration that a simple, low-technology change in how patients reach us, rather than a new drug, improves 5-year disability and drug-free remission. Here are the key takeaways from this week in rheumatology. Filgotinib met its primary endpoint in both radiographic and non-radiographic axial spondyloarthritis, giving another oral option with a safety profile that still warrants care in older patients. Shortening the referral pathway for suspected inflammatory arthritis appears to pay off over 5 years, not just 5 weeks. In lupus nephritis, failing an early proteinuria target is a red flag, but meeting one, especially with nephrotic range proteinuria, does not guarantee a complete response at a year. When IgG4-related disease relapses, glucocorticoid-based intensification outperformed adjusting immunosuppressants alone. and 2 safety-relevant messages. The rituximab biosimilar performed like the originator in a large veterans cohort, while the IMACS myositis cancer screening guideline is sensitive, but not specific, and may be improved by adding simple serological markers. That's your roundup for this week in rheumatology. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And if you have a paper you have been meaning to read, upload the PDF or paste any link at audioscholar.cc. We will turn it into audio like this one in any of 31 languages. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.